Welcome to another community conversation. I'm Robin Shapiro. I'm the board chair of Health Advocate X, and I'm delighted to welcome Jamie Cobb Tinsley to our program today. And she's going to be talking about Alzheimer's, which I know is a subject that is very, very vast, but she's going to actually help us break that down. Welcome, Jamie.
Thank you. Thanks, Robin. Thanks. Welcome, everyone. Glad y'all are here. And I just want to share with you a quick introduction for myself and how I got into this industry or working with persons with dementia and their caregivers. And probably like a lot of you, it's because I have personal experience with it. I do work at the James L. West Center for Dementia Care, and we're a nonprofit community here. We're in Fort Worth, Texas, and we serve persons impacted by dementia. And we do that through a variety of services. We have long-term care, we have day program, we have short-term rehab, we're about to have home care. So we have all of those services that are specific to people with dementia and their families or their care partners. But we have the education, which is really unique for an organization that provides long-term care. But we are here to help people no matter where they're at. So no matter where they're at geographically, but where they are in the stage of the disease and where they will be also. So really our goal is to provide that education and those resources and that support for family caregivers, but professional caregivers, organizations that might indirectly provide support for persons with dementia. And that's largely what I do here at the West Center. And what is so great about that is because I needed education as a family caregiver. So my mom, when she was in her 50s, her early 50s, she started to show symptoms of dementia. So that's young, right? I was even younger and didn't know what was going on. Our family, I could tell you guys what not to do when you start to see your loved one change and do things that are uncharacteristic, because we did the things that I'm not going to say they were wrong. We just did the things that were coping skills for seeing our loved one change. Right. So we needed that education and we needed those resources and that support. So it really was, while my role is like my career choice, it's also a personal mission of mine. And I can't see myself doing anything different, but really providing support for those families and professionals to help you through this journey that's complex, but really looking at it from a different lens. So yes, we need to know the skills, we need to understand the disease and how it affects the person, but how do we look at it differently? Instead of, and a lot of it has to do with the words we use, but looking at it where you can live well with this disease, you can have quality of life, and there's still joy to be had. I heard a gentleman say the other day, and I loved it, and I'm adopting it and stealing it, so now it's mine. But I'm saying a person with dementia is not a problem to be solved. They are a person to love. And I think that's where all of our care needs to come from. And that's why we're in healthcare, right? Sometimes that gets away from us, me included, but they're not a problem to be solved. They're a person to be loved. And that love is where that care stems from. And, very briefly, dementia, just give you a quick overview of dementia. But dementia is a descriptive term, and it describes as a group of diseases that cause cognitive challenges, changes in thinking, changes in memory, confusion, but they're significant enough to interfere with daily life. There's over 100 different types of dementia, Alzheimer's disease being the most common type. So about 60 to 80% of persons with dementia will have Alzheimer's type dementia. But there's vascular dementia, frontotemporal, Lewy body dementia, Parkinson's dementia. Those are your more common ones. And these are all progressive dementia. So a dementia caused by a neurodegenerative disease is progressive. So meaning it will get worse over time. And it is a terminal diagnosis. So if somebody doesn't pass away from something else, they will pass away from the complications of the dementia that they have. But I also want to say it's not a normal part of aging. And it's important for me to say that because that's still a really big misunderstanding or misconception out in our society, that a lot of people think, well, if I just, well, they're getting older, so it's expected. Well, that's not. There's many, many people that live until their late 90s with their brain fully intact. It might be slower, but it's fully intact because this dementia is not a normal part of aging. Now, I will say there, I'm going to give you a few statistics. About 7 million Americans are living with Alzheimer's disease or related dementia. And that's
Did you
7
say 7 million? 7 million. Okay, not
yeah.
70.
No, sorry, 7 million.
Yeah.
And that's 65 and older. So we're looking at the population 65 plus is 7 million Americans. Now by 2050, so not really too far away, that number is projected to grow to almost 13 million. So they're diagnosing this more and more. Okay. And a lot of that has to do with our older population is the largest population. Okay. So we have the oldest number of people in that 65 plus, or the largest amount of people in that 65 plus age range. But people under 65 can get diagnosed with dementia. And we are seeing that more and more, whether it's in their early 60s or in their 50s, they're getting diagnosed with Alzheimer's disease or frontotemporal dementia. So we are seeing more of that. And it's important to be aware of what the symptoms are so we can be an advocate, right, to our community members.
So is that, or is the earlier diagnosis happening because there's more awareness, more understanding of symptoms?
There's a bigger push for people to going to the doctor. If you have concerns, talk to the doctor about it. The doctors are also being better educated. Still a lot of work needs to be done, right? But they're being better educated. And we're able to, there's more advances in the testing, right? There is, excuse me, it's not quite out yet, but they're using biomarkers, blood-based biomarkers that they're really doing a lot of research in. And I suspect, I don't know this, but I suspect that's going to be the newest thing that we see as far as diagnosing goes, is because you can do the biomarkers in blood work at your general practitioner's office so that you can, and it's not going to diagnose anything, but it'll help you know, oh, there are higher levels of this biomarker, right? We need to get you to a specialist or we need to do further testing so we can be better about diagnosing earlier. Because when we diagnose earlier, we have a better chance to plan. We can get on medications that help alleviate symptoms. We can just prepare more. And right now, and for the longest time, it's not being diagnosed until people are like in the middle stages and you can't ignore it anymore, right? And that's really kind of for a lot of people too late for some of these medications that are already out there to really fully effectively work. So I think that's going to be the newest thing that we hear and that the general population can generally get and a little bit more cost effective.
And do we often also look at segments of the population where a disease is more prevalent? Are there segments to this disease or group of diseases?
Yeah, there are about women are 2/3 more likely to get diagnosed with Alzheimer's specifically. So they are doing research in how hormones play into that, but also women live longer than men. And this is our greatest risk factor is age. So the older we get, the more at risk we are. Again, it's not normal part of aging and it's not deterministic, but women tend to live longer. So you do see more diagnoses there. And then Black Americans are twice as likely to get diagnosed, and Hispanics are 1.5 times more likely to get diagnosed when compared to like their white counterparts. And a lot of this also they are expecting has to do with they have higher rates for heart disease, diabetes, high blood pressure, high cholesterol. So there's some of those things, but also disparities in health or access to the care too play a factor into that. So
makes sense.
Yeah. But it's important to understand this and understand dementia is a disease of the brain. And another statistic I want to tell you, so we got 7 million Americans living with this disease. Well, there's nearly 12 million Americans that provide unpaid care for that person living with this disease. So you got one person with a diagnosis, but you have at least two care partners that are impacted, right? And they're paying, unpaid care. It's a spouse, it's a child, it's that neighbor, it's those people who we are, right, or that we're working with. So that number is doubled, and there are some health complications that can come along with that, which I'll address a little bit later, but it's caregiving is hard. And then caregiving's even harder, I would say, for somebody with dementia because it is so complex. It is such a complex disease, and it, gets worse over time because this disease affects somebody's brain, and our brain controls absolutely everything that we do. So it goes beyond just being forgetful or pleasantly confused, right? It affects all areas. And progressively, the brain shrinks over time. Communication gets lost between the neurons. And that's somebody's not able to problem solve like they used to. They can't make decisions like they used to. They're not able to communicate using language like they used to. So the care becomes more complex. And we, as their care partners, we're the ones that have to adapt to these changes. So it's understanding and learning, well, what are these changes? And what do you mean it affects all parts of the brain? What does that actually look like? Because it's an invisible disease. We're not seeing the damage that's happening to the brain. We're just seeing symptoms that somebody presents. And that could be mood swings, right? That could be their inability to plan out their day like they used to. Eventually, it'll be physical changes that happen. So how do we, in understanding that they're not in control of what's happening to their brain and there's not something they can necessarily do, there are medications that can alleviate the symptoms, and there are lifestyle choices to help us alleviate those symptoms of stress and stuff. But it is progressive, so it is going to get worse over time. So how do we adapt? How do we learn those skills, the strength, the understanding to provide that care and step in and support as needed, and knowing that that'll change too. We have to be very adept at our care skills and strategies, and knowing that we're going to have to continuously learn care strategies and care skills. Yeah. With dementia, something that's important, and I think that's not talked about a whole lot or maybe kind of overlooked, is how important the environment plays into persons with dementia. And it's, a key idea is that the environment should work with the brain. It should not work against the brain. Just like, and I'll say this, our communication needs to work with the brain, not against the brain. Mm-hmm. So as we have an understanding that dementia affects all areas of the brain, we've got to meet that person where they're at. Or we're going to meet that person's brain where that brain is able to work from moment to moment. And this disease is so individualistic. So you probably have worked with or loved somebody that has dementia. And then you work with somebody else or love somebody else that also has dementia, and it can look completely different. While we have an understanding of how the disease will affect these different areas of the brain, how it manifests in somebody will look different. Some similarities, but differences as well, because we're all unique human beings.
Well, and that going back to that, it can feel different moment by moment too, which I think is one of the things that tests the patients very, very challengingly.
Yeah, 100%. So it's so important to take care of ourselves so we can. No, I've got to adapt from moment to moment too. And that takes strength, and it takes rest and resilience and these skills, right? But this, it's understanding with dementia, I briefly touched on it, changes communication, problem solving, thinking skills, but it's also changing how they're interpreting the environment. So these 5 senses that we all have, dementia affects the 5 senses. So it may limit them, as they're getting older, they may not hear as well or see as well. Yes. And they're slowing down, so they're not able to catch themselves as quickly if they trip over something, right? But with dementia, it's kind of adding a layer of complexity because it's not that they don't hear something, see, smell, taste, feel something. It's how they're interpreting it that's changing. So they may see their dentures sitting right there on the bathroom counter, but not put them in because they may not recognize what that object is anymore or how to use it. You know, that the brain tells me how to use it or how to clean them or what I'm supposed to do with them. And if that part of my brain's not working in that moment, then I'm not going to put my dentures in. Or in our community, you might put somebody else's dentures in and not aware that they don't fit quite properly, right? You know, I went and visited my grandfather once when he was in the group home. He had dementia, and I was looking at him, and I was like, "There's something just not quite right about how Grandpa looks. What is happening?" And it took me a long time to realize he's got somebody else's dentures in his mouth. It changed the way, and he wasn't aware that it wasn't. He was a little bit agitated because it was uncomfortable, but he couldn't tell me there's something wrong with my mouth, or I think I've got somebody else's dentures in, right? And I laugh at this because it is humorous, and it goes back to, I'm not laughing at my grandfather and I'm not laughing at the disease, but we do have to find humor in the situation, right? So when that happened with Grandpa, and I was like, and I finally kind of figured it out, and it came to me, and I was like, "Hey, Grandpa, you know what? I think we need to eat something really, really good. Aren't you hungry? I'm hungry." And he will love sweets. Most people with dementia do love sweets. So I got a cookie, and I said, "Oh, I tell you what, this cookie is so good. I want you to really enjoy it. Let's really enjoy it with our tongue. Let's get those dentures out of there and really just savor it and hold it on your mouth." So I was able to get him to take the dentures out using sweets, and then I don't think we found his dentures that visit, but of course we made the community aware of it or whatever, but it wasn't uncomfortable anymore, right? So we took care of that need. So, but it's looking at those. The same thing with not seeing something, or they misconfuse objects. They might see a remote control sitting there, but confuse it as a telephone. So they're trying to call somebody on the remote control. So it's not that they don't see it, right? They're just not recognizing the object. And you will see, this is so common, you will see somebody with dementia, they will put down the knife first, they will stop using the knife, then they will stop using the fork, then they will stop using the spoon, and then they'll start eating with their hands. And it's not that they don't see the fork or the knife next to the plate, it's just they don't know how to use it anymore. So it's that interpretation. So with what we're seeing, with what we're hearing as well, they may hear the fire alarm go off and not know what to do with that sound, or it reminds them of something from their past. We had a gentleman, the fire alarm went off here, and he actually happened to be in the Pentagon when 9/11 happened.
Wow.
Now, we couldn't tell him, "Hey, you're here at the dementia care center and you have dementia and it's just a fire alarm," and it got stuck, unfortunately. It's just stuck. We need to just calm down. We couldn't tell him that because we had to meet his brain where he was at, right? So he went back to, we got to get everybody out of here. We got to evacuate the building. He was going back to his past. So we had to meet him where he was at, and we evacuated one small area till we have a gazebo area. So we got everybody out to that gazebo area. You could still hear the stupid fire alarm. Luckily, we had some drums, like beating drums on the balls. So we started beating to this rhythm of the fire alarm, right, to help with that restlessness and that energy. But we had to meet them where they were at because we can't expect to pull them into our reality and understand and reason with them. Same with taste, same with feel. And that's important, particularly as they advance more into the later stages of the disease and pain, because can be in pain, but they may not be able to tell you, or somebody's recovering from, hip surgery, or they're in rehab and they continue to try and stand up out of that wheelchair, but they don't remember, "Oh gosh, I just had hip surgery and it's going to hurt if I put weight on that." But they try and stand up and now they're agitated or they're in pain. And so we got to be aware of setting the environment to help them be successful. If I can put myself in their shoes, so that's And it's making a calm environment. Can we turn down the lights as needed or turn them up if we need more lighting in there? Well, how noisy is it? Is there a lot of people in the room? Is the TV on way too loud? Are we talking too loud and it's just hard for them to filter out background noise? Even in the early stages of dementia, persons with dementia have a hard time filtering out background noise.
Mhm.
So this can be if you got your air conditioner on really loud, there's people in the hallway or in the other room talking, the TV is on, we've got the radio on, all of that noise that a healthy brain can ignore really and focus on what it needs to focus on. Somebody with dementia is less able to do that. And as the disease progresses, they're less and less able. So even that background noise to us can be overwhelming, overstimulating. And what do we do when we're overstimulated? We respond. We either try and escape, I got to get out of here because it's too much, I'm leaving. Or we get agitated. This is some crap. I can't believe this is happening. Our anxiety raises. Or we become more restless. We have more negative energy because of the stimulation. And it's the same thing for somebody with dementia. They're just not able to necessarily verbally tell you, gosh, it's really loud in here. Can we turn down that TV? Because it's bothering me. But they're going to tell you through their expressions.
Mhm.
And that's another key point for somebody with dementia is that nonverbal communication is key. Absolutely key. Again, we got to meet their brain where they're at. But it's also, a key idea we like to say is when words fail, feelings remain.
Mm.
So when words fail, and words will fall for people with dementia, they lose their vocabulary, they can't verbally communicate. But those feelings, those emotions, and those reactions are going to remain. So they're going to react to their environment. They're going to react to our care approaches. And they're
So
going to
when,
use what they
yeah,
have left. Yeah.
it's super important for people who are doing the caring to notice and also provide some opportunity for them to interpret or communicate what's happening.
100%. Yes. We have
Mhm.
to be, and I think if you don't, the best skill you could develop for anybody is
Mhm.
to really learn that nonverbal communication. And that's listening to what they're telling you. And it might be the words they're using, but it's really more the feelings behind the words they use because the words may not make sense. But that feeling, I can tell they're upset or I can tell they're really restless or agitated about something. Well, that's what I need to respond to. Or I can tell they're scared or they're sad. The words may not be telling me that, but their feelings and emotions are. Or if they're resistant to my care or they're not cooperating, well, they're telling me something, and
So
I
is
have
it,
to be the one
so
to
is
figure
it,
it out.
it, so do you suggest even just noticing and saying you seem upset,
Mhm.
something
Yes.
seems amiss, you know, let's
Oh,
work on
yeah.
that together? Or
Mhm.
is that more frustrating for the person who can't communicate well?
No, Robin, you hit the nail on the head. We have to validate their emotions. And, an example I have is we had a woman who was I mean, she was mad about some stuff. But what she was saying is somebody stolen her shoes. And she was so mad about somebody stealing her shoes. And I knew nobody stole her shoes, right? So as a care partner, I wasn't going to go back and say, well, now, Miss Jones, nobody has stolen your shoes. I think they're probably in your room. You just don't remember having them, or you misplaced them. You put them down somewhere. It wasn't that. She was mad about something completely different. She
Hmm.
was mad because she was overstimulated. There was we had ballroom dancing going on in her house that she was in. So there was a lot more people. There was a lot more noise. She got overstimulated. But the words came out, somebody stole my shoes, but it was the feeling. So when you,
Hmm.
in that instance, Robin, you validate that emotion. You say, this is upsetting. I cannot, and you can say, I cannot believe that has happened. That is some crap. So you meet them where they're at,
Mhm.
right? And sometimes you meet them in that emotion. But that's where we got to take that frustration or anger or sadness, whatever they're expressing, and redirect that into something else. And sometimes we've got to fix it. I tell you what, and I told her, it's like, come with me over here. I took her to a quieter area of the house and I got on the phone and I called and I said, we're going to report this because I cannot believe this has happened. And I'm validating her.
Mm-hmm. Mm-hmm.
And she felt heard.
Mm-hmm.
And somebody was there to help meet her need and was listening to her
Mm-hmm.
and was on her side. We got to be on their side, right?
Yeah.
We got to be their friend and get on their side.
Right.
No, I got to redirect you.
Yeah. We have a couple questions here. One is from Lee, who is a health advocate, and she said that she's had several conversations lately with a client of hers whose wife has Alzheimer's regarding whether his wife is in denial regarding her memory loss or whether her physiological condition prevents her from having insight, like damage to her brain, actually preventing her from realizing her memory is not functioning well. I'm imagining that this is most people at some stage if they're in a relationship. And it's really frustrating for him and her because she can tell that something is wrong, but not sure what stage she's in. And so that seems like a tangle that I would imagine most couples face
Yeah.
as this is progressing. How
Yeah.
do you how do you help them
Mhm.
untangle?
Yeah, it's very common and it's difficult because most people, it could be a combination of both those things. It's they're in denial, which is a coping skill, right?
Mhm.
So they're
Mhm.
just coping with it.
Not happening.
Yeah, yeah, well, because we want things to go back to the way they were, right?
Mm.
Um, and so it could be there's denial, there's some other things going on, but they're just confused. Like most people, not everyone, but most people know something's wrong. They just can't tell you what, or they can't verbalize it, or because there is confusion and memory challenges and thinking challenges. Just something's wrong, and I can't tell you. Um, Now it's rare, but there is an occasion where somebody is not able to tell you. So they don't recognize their own changes or their own losses. And that
Mhm.
has to do with some changes that are happening in the brain. It is more rare, um, but that can be a factor. Here's the other thing that makes it more complicated. In one moment, she may not truly recognize that anything is wrong with her, and in the next moment, well, something's wrong, but I can't figure, so it can come
Mhm.
in and out, if you
Is
will.
that where diagnosis and having a diagnosis and staging is helpful?
It is helpful. Your approach to how you manage it with the person is going to stay the same, right?
Mm-hmm.
Because what typically does not work is to go back and say, well, you have Alzheimer's disease and we're in stage 2, and this is a normal part of it. And you just need to go over there and sit in the chair and everything's going to be okay because I'm going to take care of you.
Mm-hmm.
Well, it's kind of invalidating, right, to say that to somebody. And they may not believe you. And more than likely, you're just going to have to tell them again anyway. And that can be upsetting. I have Alzheimer's disease. Oh my gosh. Or I don't have Alzheimer's disease. You're just trying to make me be sick, whatever. You get all these
Uh-huh.
different reactions. So it can be upsetting, and we don't want to upset them. And so this is where a lot of reassurance comes in. And again, it goes back to validating that emotion of, you know what, and you can say there's some changes happening with your brain where we've talked to the doctor about it. We're going to do these medications. We're going to do daily walks. It's a lot of reassuring. You can talk about it as long as it's not upsetting by
Mm-hmm.
any means.
Mm-hmm.
And but if it upsets them to say, well, you have Alzheimer's disease and here you are, then we don't want to continue to do that. But it could be, yeah, you were a little sick. We got some things happening, but we've got a treatment plan in place and we're here to take care of each other. We're going to do this and we're going to be okay. Why don't we go over here and get a cup of tea? So you address it, you validate the feeling, whether it's fear or it's anxiety, and you reassure it. I'm not saying we can fix it, but we
Mm-hmm.
reassure them and then we redirect them to,
Mm-hmm.
let's go get a tea or let's go for a walk or we're in this together. It's okay for somebody with dementia to be sad. It's
Mm-hmm.
okay for them to be mad. It's
Mm-hmm.
okay for that. And a lot of times we all need to be sad and mad, and we need to have those emotions because we're human beings.
Mm-hmm.
And then we do something else. We just have to facilitate that something else. Let's be upset, let's be sad, but then let's go get tea, or let's go for a walk, or let's go for
Mm-hmm.
a drive, and redirect and distract from there. And I hope that answers the question. But that's not uncommon.
Yeah.
And as the disease progresses, people become less and less aware of what their abilities are. So in the early stages, there's something wrong, but I can't quite tell you. And I may use humor, I may use anger, whatever it is. But as they progress, they do become less and less aware of their the changes that are happening,
Mm-hmm.
which is bittersweet, I think,
Mm-hmm.
because as their care partner or the person that loves them, they're less and less aware. But I'm seeing it more and more,
Mm-hmm.
right?
Um, so a few other questions here. This one from Senya, thank you. You talk about meeting them in their environment, but if the physical environment is no longer safe, like stairs and obstacles, what's the best way to evaluate a new environment and how to familiarize the individual in a new environment? Because I know that also changing the environment can be super stressful.
Yeah, that is a fantastic question. So if we can identify early on if there's going to be changes to the environment, we need to make them as early as possible, even if we might not need them right now. That
Mhm.
way, because in the earlier stages, they can adjust better, or they can adjust quicker to the changes in their environment. Because that might be we move everything from upstairs to downstairs, or we're installing ramps, or whatever it is, or I move into mom's house, or mom moves into my house, whatever it may be. If we can make those early on, that's the best scenario. But that doesn't happen all the time, right? So we make the changes, we keep it as familiar as possible. So even if we had to move mom into my house, then I need to bring the comforting, familiar things of hers with me. And that way we can make her environment familiar as possible. We need to make it friendly, a place that she wants to be. And we need to make it functional too, thinking about that she can move around as independently as possible, where safety happens. But there will be a time where that transition is hard for her. She's going to be more confused. It's unfamiliar to her, right? And we just need to allow that time and expect that there's going to be this adjustment period. And for some people, that adjustment period might be a few days. Some people, it might be a few weeks. Others, it might be a few months. And that can look like where they're just more confused, more easily agitated or restless, all the way up to they're packing every night because they need to get home,
Mm-hmm.
right? Or
Mm-hmm.
they could be doing this in a house they lived in 50 years too. But they're trying to go back to something familiar. And if
Mm-hmm.
we can provide that familiarity from their childhood, so it may not necessarily be the house they lived in for the last 10 years, but what was familiar to them as a child? Because it's like they're progressing in their timeline, like their own personal timeline. So it's not, they're not the 70-year-old mom that came to live with her daughter, but she might be the 50-year-old mom. And what was she doing then? And what are some things that were familiar to her in that time of her life that I can
Mm-hmm.
incorporate now? Yeah.
That's a really interesting
Mhm.
idea.
Yeah.
So Kimberly Russell asks this question, which is more for helping the caregiver. I know a man showing signs of dementia. The wife wants her husband to go back to the way he used to be. How can you help the spouse who may be in denial of her husband's dementia?
Mhm.
That's a
Yeah,
good question. So
it is.
tough.
Yeah,
Mm,
education.
yeah.
Yeah, and it's respectful education, but it's also it's hard. It's hard to learn about this disease and what it does. And there are, videos you can watch on YouTube. I'm sure, coming to this website or YouTube channel, you can find these things and pull out snippets because it
Hmm.
might be, let's just learn from an expert. Well, here's what dementia is. Here's
Hmm.
what the stages look like. Now, we don't want to give too much information because that can be overwhelming,
Yeah.
but knowing at least that dementia is a disease that they're not going to go back to the way they were.
And maybe even get the spouse to some kind of a support group or in
Yeah,
touch with somebody who's experienced that,
yeah,
um,
yeah.
to because I'm imagining the spouse is grieving the loss of the relationship and also whatever future,
Mhm.
care will be required that maybe some people are not really well cut out or suited to give. What you're saying in terms of what the caregiver needs to do, not everybody might be able to be that to their sick spouse or loved
Yeah,
one.
yeah,
So
yeah, absolutely.
getting support. I have a comment from Jenny Adamo from Bannister. Hi, Jenny. She said a common theme I'm finding in doctors who give a dementia diagnosis with minimal testing, she adds, is that they give the diagnosis and then they leave the family with no follow-up resources. So, what's the best way to support families during this early stage other than referring them to a specialist? Yeah, good question.
Changing the whole healthcare system. That's
Yeah.
it. Can you do that? That is such, oh my gosh, we were just talking about this the other day because it is such a huge concern. So a doctor, I mean, if your doctor does minimal testing, then you do need to go see a specialist because we want to get the right diagnosis for sure. So a specialist might be the right thing. In the meantime, however, if they say I need to go see a specialist, in the meantime, let's do some of these lifestyle choices, which I'll talk about briefly. But it's unfortunate that the doctors just leave you. Here's your because the doctor would still say, well, here's your diagnosis. I'll see you in a year.
Hmm.
I mean that's it's like trauma getting this diagnosis, and then what do
Hmm.
you do? Um, and I think it's probably where your organization with Health Advocate comes in to set in. You just got a diagnosis for dementia. Well, here are some certain things that you can put in place. What we
Hmm.
always recommend is make sure that you talk to the doctor about starting the medications that help alleviate the symptoms. So there's some symptom management medications that can get on getting your financial affairs in order, especially while that person can still talk about their wishes and wants and values.
Hmm.
Go ahead and travel, do all the things you've wanted to do, because there will come a time when that person with dementia can't go travel or they can't go see the grandkids that live in another state. Or maybe I wanted to get a new puppy. Now is the time to kind of do all of those things and then start preparing for educating yourself. Okay, so what can I expect? What are things that I may not need it right now, but I might need it in 5 years? And we're just starting to kind of gather those resources. Unfortunately, we really kind of have to do that on our own or reach out to a group like Health Advocate to help us do that.
Hmm.
Um,
Yeah, and I do want to mention that we hosted, some of you online might have seen Annie Jacobson's Navigating Early to Mid-Stage Dementia session that was done in December. And Chloe, if you could post that into the chat to Classroom, it's still available. You can watch it for free or you could get a CE for that. So Chloe will post that in the chat in case you're interested to look at that as well. It was super helpful. Um, so Angie, lots of questions here. I'm looking at our time, but Angie Galatas says, I have a dementia, Alzheimer, or possibly mixed with frontal temporal as she has anger, distractibility, difficulty focusing, yet fairly good system. However, she gets irritable to me as her advocate because she keeps saying she can't afford it, yet she can, according to the family. It's always a subject of anger with her. Any suggestions on how to work around that? It's a good question.
I would talk with the family about using a therapeutic story for that.
Mhm.
Because the therapeutic story could be that our services are free.
Mm.
So you should
Mhm.
just take the money aspect out of it.
Mm.
Well, our services are free. Or we have a donor doing this, or
Mhm.
something like that. But making sure that like everybody in the family has that same story to
Yeah.
tell, because if that's a worry for it, well, let's just get rid of it. Let's just get rid of that
Mhm.
worry,
Mhm.
or I'm volunteering my time to do this because great friends with your family, or I love you, or whatever it is. Just
Mhm.
get rid of
Mhm.
that, and but
Mhm.
make sure everybody has the same story to tell.
She says thanks. She still sees all the bills.
Oh,
Ah,
oh, she does. Well, is there a way you could bill somebody else? Um,
yeah,
or uh, or use a different kind of system for payment
yeah,
if that's
yeah. Um, so let me see. And I know that we still had a lot of content to cover, so I'm going to go back to ask, especially about the creating a supportive home environment.
Mhm.
And we did have a question about, and it is really delicate, I know, like when's the right time to move? Like, how do you
Sure.
know if
Yeah.
it's the right time to move?
Yeah.
Yeah.
You don't. I mean, that is it's so different for each person, right? But we always come back to safety, and it's physical safety and emotional safety. So these are
Hmm.
really your two barometers or parameters. Physical safety for the person with dementia and the caregiver. So the one providing that care. If it's too physically hard, or it's a safety factor, then that's a move. But then there's the
Hmm.
emotional safety for the person with dementia, but more so that primary caregiver, because it's 24/7. It will be a 24/7 caregiving role, because eventually that person will need 24-hour hands-on care where they are not able to do for themselves anymore. And that's physical exhaustion, but it's emotional exhaustion, it's mental exhaustion, it's Robin, you mentioned it earlier, but there's the grief of all
Hmm.
of this. So and the grief is different from physically losing a person that we love, but I'm losing the future. You mentioned that I'm losing the relationship I've had with my spouse, or it's changing. I'm losing,
Hmm.
my person that takes out the trash. I'm losing the person that writes the checks. All of these griefs. And then as the disease changes and there's something else, like they move into another stage of the disease, well, that's another normal, or
Hmm.
that I've got to adjust to as that care partner. So it's emotionally
Hmm.
exhausting. And there will come a time where I've yet to meet the person that can do it all by themselves 24/7.
Yeah.
It's just not humanly impossible. So we
Hmm.
always say it's those two barometers of physical safety and emotional safety for both
Hmm.
people. And that'll
Hmm.
look different for each family or each situation. But that's what you can kind of gauge it against for a move.
Do you recommend, are there like podcasts or books or things like that that would be supportive to the caregiver and not scary, but like additive to the situation?
Yeah, I mean, there's the 36-hour day, which, I kind of have a love-hate relationship with that book because you get a lot of skills out of that book.
Mm-hmm.
But it can be overwhelming for some people. But if you just
Mm-hmm.
take what you need, like you just read,
Mm-hmm.
like you can read the index, oh, I need to learn about
Mm-hmm.
toileting. Then I just
Mm-hmm.
read that, then that's all
Mm-hmm.
I take. But that you get a lot of skills and a lot of
Mm-hmm.
practicality out of that book. But
Mm-hmm.
there's also another book. It's good. It'll come to me in a minute, but
Okay.
it was a famous coach, and he did like it was kind of like a playbook. But and there's
Mm-hmm.
another one. It's loving. Sorry, I'm looking over here to my bookcase. Um, it'll come to me. But there's one called Love Remembers, and it's by Kathy
Mm-hmm.
Goodwin, and she is a caregiver. Her husband
Mm-hmm.
had frontotemporal early stage, and she reflects back. He's passed away. She reflects back on her
Mm-hmm.
entire journey, so you get to
Mm-hmm.
hear that caregiver's story,
Yeah.
which is just great to hear. But there's
Mm-hmm.
another one I want to. It'll come to me, but the gist of
Mm-hmm.
it is that a gentleman was taking care of his wife, and the relationship changes.
Mm-hmm.
Whether you're a spousal caregiver or a child caregiver or sibling, it just changes. But and they call it the hidden widowhood
Mm-hmm.
because you don't
Mm-hmm.
have that spousal relationship anymore, right?
Yeah.
But it's looking at a different perspective. So,
Mm-hmm.
My Two Elaines, that's the name of the book. Sorry,
Okay.
My Two Elaines, there it is.
Mm-hmm.
But it came back to, well, I'm not the Elaine that I married is no longer the Elaine that I married,
Mm-hmm.
but she's my new Elaine.
Mm.
So I've got this new relationship with
Mm-hmm.
Elaine. Not the
Mm-hmm.
woman I married because she's
Yeah.
different,
Right.
but I've got this new Elaine. So it's changing that perspective.
Mm.
Um, and to be able to do that, I will kind of going back to that other question about when it's time to move.
Yeah.
He was able to do that because he had people put in place to help him with all the daily care management stuff. He wasn't
Mm-hmm.
there doing the showering and making sure she was eating her meals and getting her ready for the day, but also being going back to being that husband relationship. You can't do all of that.
Yeah.
You have to have that help and that support um, to go back to have. And we tell a lot of people when you move into our community, let us take care of the ADLs and the
Yeah.
medication management. That's what we do. That's what we're experts at.
Mm-hmm.
You come back to being that spouse. You come back to being that child. It's going to look different, but you
Mm-hmm.
come back and start nurturing that relationship, which
Yeah.
is that quality of life.
We have a question from Sheila Carter. Can you speak on the wandering dementia patient? On the wandering dementia patients, and why does it seem to be that they mostly wander at night, really exhausting for caregivers who work full-time jobs and then have to watch the loved ones to maintain their safety? Are there medications that can help with restlessness and wandering? Well, and I think there are also different devices also that
Yeah.
can
Mhm.
help with
Yeah.
that. Can you address that? Thank you.
There are the wondering is because or the sleep wake cycles, the circadian rhythm, all of this changes because that's controlled by our brain,
Mhm.
and that's the part of the brain that's being affected by the disease.
Mhm.
So the sleep wake cycle will, for most people, get interrupted and it'll get topsy turvy and it will change. So where they are up at night, and maybe sleeping more in the day, or they're up at night and still up all day, long,
Mhm.
because that part of the brain's being affected. Now, as far as medication wise, you can work closely with the doctor about providing medication that helps with sleep. And that might be an option, but we always want
Mhm.
to try these non-pharmacological options first, and that is making sure it's safe. And we have to ask ourselves this too, because mom's getting up in the night and she's packing or she's rearranging the cupboards in the kitchen, does that mean I have to get up? She's safe, she's not trying to leave, she's just doing what's normal for her in that moment. But I don't necessarily have to get up. So a lot of families use monitors, whether it's a sound monitor or a video monitor in their room, so they have eyes on them, right? They make sure the whole house is locked up so they can't get out. A trick is if we put locks at the very top of the door, people with dementia don't generally look up,
Huh.
or at the very, very bottom. So there's some
Mhm.
safety kind of things there that we can put in. You can air tag them, their shoes or their pajamas or whatever it may be.
Mhm.
So there are things that you can use. There is home care that can come in, so you have somebody there at night so you
Mhm.
can get a full night's sleep, or you have somebody there to watch her if she gets up, or redirect her, entertain her, or whatever it may be. Or you can talk to the doctor about medications. There's melatonin that can also, which is an over-the-counter
Mhm.
uh, supplement, which is a natural occurring hormone in our body that, as we get older, our body doesn't release it as well. But with dementia, it's the same. That whole hormone that gets released gets affected by the changes of the disease. So you can start adding melatonin, but I implore you, please, 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 you have to work with the doctor and you have to work with the pharmacist about that. It's not just as easy as going to get something over the counter. It's a
Mhm.
little bit, we just need to work with them on doing that because it can also interfere with other medications that might be prescribed. That
Mhm.
also might be a point if you can't have somebody helping you with that, that's a safety issue that I mentioned earlier, because if you're not sleeping, that's a safety concern.
Mhm.
So,
For sure. Yeah, thank you for that question. All right. Um, so I want to just make sure that we've gone over all the areas: creating a home environment, nonverbal communication, and managing the emotional challenges of caregiving and maintaining personal well-being. Those are our three objectives for this talk. Um, I wanted to ask a question about whether or not there's like any kind of online community that is particularly good, or I would imagine that that would be really helpful to just know that you're not alone in this space. Um, any suggestions in that area?
I would suggest looking at your local areas for support groups.
Mm-hmm.
Um, yes, I like online communities, but sometimes you get those people that offer unsolicited advice that may not be good advice either. So you kind of have
Mm-hmm.
to wade through some of that stuff.
Mm-hmm.
So that's why I always suggest to reach out to your local Alzheimer's
Mm-hmm.
Association or your area agency on aging, since they have the support groups in the area
Mm-hmm.
that a lot of them you can connect in person, but a lot of them also have online things that would be specific to whether it's Alzheimer's disease. There's the frontotemporal dementia association that does support groups. There's the Lewy body dementia association that does support groups. So I would suggest going to those leaders in those fields to look for
Mm-hmm.
support groups in your areas or chapters that they have.
And they
Because you're
often,
getting experts.
yeah, that's
Yeah,
a good suggestion. And sometimes those areas also can identify local respite.
right.
Um, yeah,
Yeah,
for
correct.
people. Let's see. So Maggie Buckley said my uncle's doctor approved the use of CBD gummies, which my uncle had been using pre-diagnosis for sleep management.
Well,
My uncle enjoyed having his bedtime candy as his condition progressed. As Jamie said earlier, appealing to the sweet tooth urge when medication changes were made, he was given a similar looking gummy candy.
awesome. Yeah,
Thanks for sharing that.
yeah,
Yeah.
that's great. Mhm.
So in the last few minutes here, as we wrap up, what what would you like to? I
Mhm.
know there's a bunch of stuff we talked about that we didn't get to yet, but
Well, I will say, we talked about the importance of education and knowing this disease and understanding that we have to accommodate and adapt to the changes of the disease and meet them where they're at. But that takes self-care on our part to be able to do this. And it's so important. And I think it goes overlooked, even though people like preach it and we hear about it all the time, but we don't actually implement it a lot. I think as caregivers, whether we're families or professionals, but the importance of well-being for you as that care partner. Because if you're not sleeping well, you're not taking your medications like you're supposed to, you don't have the energy, you don't have the patience, you don't have the kindness, not intentionally, we just don't have it because it's being used up for something else. Then we're not able to provide the best care that we set out to provide in the first place. So we might go back to our old ways of, there are things that we would not necessarily want to do, right? Our uncharacteristic, or not uncharacteristic, but our old habits of stuff. And when we know that we can do better, but we have to be able to take care of ourselves to be able to do that. So it is allowing us time for self care, for getting that rest, asking for help when we need it, and saying, I'm having a hard time. I'm not sleeping. I need to go to the doctor myself. It's been a couple of years. I just need to get a physical and see what's going on.
Mhm.
These things, or I just not had time for myself. It's making that a priority, and really, one of the few things that we can control in our lives is how we can control our time and what we do with our time. And it's important for us to make time for ourselves. It's not selfish. It's not something we need to feel guilty about, because we have to be able to provide the care we set out to provide, but we have to have the energy and the tools and the fuel to do it.
Mhm.
And we're the only ones that are going to be able to do that for ourselves. Somebody else isn't going to. So please know that that's so important. And it's little things that we can do. It's choices that you make in your diet every day. It's drinking more water instead of sodas. It's going for a 5-minute walk. It's sitting, going outside and feeling the wind. It's little things. I'm not asking you to take a big long vacation. If you can do that, great, do it. But it's little things that we start doing every day, little
Mhm.
short check-ins that just become part of our day, and it becomes part of who we are, and then it becomes part of the care that we provide.
Mhm. Great. Well, this hour has flown by as we knew that it would, and really appreciate everybody tuning in and asking all these great questions. And thank you, Jamie, so much for sharing your time and your wisdom. Really
Thank you.
appreciate all the tips and learned a lot. I made a lot of notes myself. So, I mean, I think we're all going to be either have already dealt with this issue in some way or will be. So, very timely. And thank you again, everybody. Have a wonderful, wonderful afternoon. And it will be available in Classroom in case you came late or want to share this with someone else. Bye bye.
Thank y'all.